Okay, welcome everybody. We're here on the lands of the Wurundjeri people of the Kulin Nation who have gathered here for tens of thousands of years. I pay respects to their past and present elders and to all First Nations people who are with us, from whom there is so much to admire and to learn, including how culture and country and body, mind and spirit come together in an integrated whole and an understanding of social and emotional well-being. As experts in the health of the people, it's up to us not only to acknowledge and pay respect, but also to commit to action. We each have things that we can do. My own commitments are to walk with Indigenous people, to learn from them and enable others to do so, and to advance the health and well-being of First Nations people in all that we do. I'm Russell Gruen. I'm the Dean of the College of Health and Medicine at the Australian National University. And as the National University for all Australians, constituted under federal legislation to serve Australia's people, its future and its place in the world, by being, as Nugget Coombs famously said, a powerhouse for social reconstruction, I'm particularly pleased that ANU is a World Health Summer program partner and sponsor of this session on clinician-led health system reform. Over the next 90 minutes, I want to tackle a contradiction that is obvious to every Minister of Health and most of us in the room, that almost every successful health policy initiative has a clinician or clinicians driving it, and yet most Ministers of Health would say that the greatest obstacle to successful and significant health reform are clinicians. So what is the role of health system reform activity of clinicians? How do we need them to lead? And how do we need them to follow? And what must we do to prepare clinicians to engage and work in transforming systems that are changing rapidly and will look very different in the future? To answer these questions, I'm joined by a distinguished panel. To my left, Alison McMillan is a registered nurse and critical care specialist and the Australian Government's Chief Nursing and Midwifery Officer. She also held leadership positions here in Victoria, including Chief Nursing and Midwifery Officer, Director of Quality Safety and Patient Experience, and Director of Health Emergency Management. Next to her is Nicholas Jones, who's a medical doctor and public health physician who is Director of Public Health at Marutahorora, the New Zealand Ministry of Health. His previous role at the US Centres of Disease Control and Prevention, he led a team developing national environmental health indicators. Jemisa Tudravu is an orthopaedic surgeon and the Permanent Secretary for Health and Medical Services in Fiji. He's also been Medical Superintendent of Colonial War Memorial, Labasa and Lautoka hospitals. Anne Dogan is a gastroenterologist and Chief Executive Officer of the Australian Commission for Safety and Quality in Healthcare, where she's been in senior roles since 2014. She's also been Director of Clinical Governance at Hunter New England Local Health District. And Steve McLaughlin, who's an intensive care and infectious diseases physician, Director of the Intensive Care Unit at the Alfred in Melbourne, as well as being Clinical Director of the Australian Living Evidence Collaboration, including the COVID-19 National Clinical Evidence Task Force, and a Technical Officer in the Health Emergencies Program at the World Health Organization. I've asked each of the panellists to share one key reform they'd like to see in their relevant health system and the role they need clinicians to play. It will be a conversation in which I hope you in the audience participate. There are microphones there. I'm a responsive MC. Put your hand up, go stand up. We'll come straight to you. But to kick off the conversation, maybe start with you, Alison. If you could change one thing about the health system in which you operate, what would it be?
For me, I believe it would be that we move towards seeing more mutual recognition amongst all of us as health professionals in the individual but meaningful contribution we all make to the health system. In my mind, we each play our role and we're not in a hierarchy anymore. And one of the things I'd love to see is the value of nursing and midwifery really be recognised for the important role that nurses and midwives play in our system.
Obviously, we're at a time when scope of practice is under the microscope. And you've been part of a scope of practice review. How does that come to bear on what you've just raised?
I think that there's enough work for everyone, without a doubt. And that those traditional silos in which we, in particular I feel in primary care, as you said, Russell, I come out of a critical care background where I feel that it was always for me, although a long time ago now, a great example about how each of us played our part in ensuring the very best of care, the safest of care, in an environment between all of the health professionals involved in those who are critically ill. Unfortunately, what I'm seeing at the moment is a little bit too much, perhaps, turf war, rather than coming to the table and talking to each other about how we can ensure safe, high-quality care in primary care, but how we can do that by being a little more flexible in our approach. And so we don't want to see turf wars, and we certainly don't want to start fighting amongst each other, because there's certainly plenty of work to be done without that. So that would be, I think that is a challenge that we will work through Mark Colmack's work. And I think that it's the beginning of a journey. I don't know where it's going, but I think in perhaps 5 years or 10, we'll look back and say, wow, how different was it then to what it is now?
Thank you. I think we'll come back to scope of practice in a minute. Nick, can I get you to pick up that microphone? You've been significantly involved in large-scale health system reform. I think it'll go on automatically.
Is it on already? Yep.
Yep. Tell us about what you're doing, and feel free to introduce us to the New Zealand context.
Yeah, thank you very much. Look, I'd like to start, as I am visiting here from Aotearoa, New Zealand, first acknowledge the Ngāti country and the people of that, but also to acknowledge tangata whenua of Aotearoa, New Zealand. And I'm just going to do that with a traditional opening. Mori tū, Māori ora, ko tēnei te Māori ao, ko tēnei te Māori o Tuanuku, ko tēnei te Māori o Tuarangi, ko tēnei te Māori o Ngā Atua, a ngā tūpuna, tō ake, tō iho, whakatau Māori e te Māori, tihe Māori ora. And that's really acknowledging the life force. I will briefly just mention, do an introduction in te reo, which is I tipu au I raro o te maunga o Waitakere I te taha o te marae ora kei kauhei au I roto I te moana o Waitemata me te moana o Tasman. Ko Ngāti Waira, ko Ingarihi, ko Wiwi hoki o ko iwi. Ko Nicholas toko ingoa. Kei te noho o kite te mata inai. Nō reira, tēnā koutou katoa. And that was really just introducing my proximity to the land, to the sea, and my ancestry, and also where I now live. So that's my introduction.
Thank you.
So moving on to the one thing. Well, of course, it's not one thing, is it? We have undertaken the largest health system reform in a generation in New Zealand. We're into our second year of it. And there were actually 5 things that government set out to achieve. There were 5 system shifts. And I can reflect on perhaps the part that clinicians played the most role in. But the first was to acknowledge the Treaty of Waitangi and the way in which our health system had failed to acknowledge and to implement that. Prior to the health system reforms, there was, and is still ongoing, a tribunal, the Waitangi Tribunal was investigating the health system's performance for Māori, and in particular primary care and mental health, where it was shown to be inadequate. So that was the backdrop, and then the government asked for a health system reform review to be undertaken, and the first priority was, in fact, to ensure that the Treaty of Waitangi was implemented within the health system, and in particular the second article of the treaty, which is really around the notion of tēnaranga tiratanga, which is Māori being able to design the services that meet their own needs. The second system shift was actually to shift the delivery of clinical services closer to home with a focus on prevention. The role then of clinicians in particular was acknowledged in the notion of creating clinical networks, which basically allow clinicians from local services through to national services, tertiary services, to be linked in a way that's more efficient and effective. The fourth was around digital enablement. And then finally, the fifth shift was really around being much more purposeful and training and planning our workforce and being prepared for the future. So, I mean, I reflect on those system shifts. I think they're all the right things to be thinking about. One thing that perhaps is a little bit not clear in that list was actually the role of whānau voice or family voice and the importance of listening to community, which is also part of the general proposal around our health system reform. So I'll leave it there for the moment, but something to think about.
Jemisu, you're one of a number of surgeons in very senior health system leadership roles across the Pacific. Maybe you can tell us why. How? I think you just talk. There you go.
Bulavanaka Russell, it's good to see you again after many years. Bulavanaka to fellow panelists, and certainly Bulavanaka to the members of the audience. As you've heard, I started off as a medical officer and an orthopedic surgeon, and gradually, graduated to become a medical administrator over the last 10 to 15 years or so. In my working life as a medical doctor, then as a medical administrator, and a civil servant, I've lived through, facilitated and led a number of reforms in the health services in Fiji. As you may know, health services in Fiji is primarily public service. So the public sector, or the Ministry of Health and Medical Services, carry the heaviest load in terms of health services. The private sector in Fiji is a lot smaller. And so that's where my experience have been, and also my learning in terms of reforms and changes in the health service. If there is one thing that I might like to change, given my experience, I participated in reforms. The first reform was in 2002, and I was a young surgeon at that time. And I'd already undergone the challenge of changes, and also the learnings that I've got from those experiences. If one thing that I'd like to change in the position that I now hold is to provide an environment and a pathway that inspires and empowers clinicians who wish to make a change, to institute a reform, to be able to do so, whether it's in a clinical sphere or in a non-clinical administrative sphere, to assist in setting up the policy space and the operational space, and resource that nurtures them, empowers them through coaching and mentoring, as they said about in implementing the change that they want to do, whether it's in all sizes, in all forms of change, whether it's clinical, whether it's administrative, the small changes that we do in the unit, or the big one that impacts the whole university or the whole hospital or even the whole Ministry of Health. I was stumped a little 2 weeks ago. I came across a young doctor who came with a request. And he's now requesting to the Permanent Secretary for Health and Medical Services. And he's asking, and he's telling me that he doesn't want to do clinical work anymore. He wants to go into administration, health administration. And he's just a couple of years out of medical school. And I was trying to convince him otherwise. You're throwing away an opportunity to grow in your professional career. You'll get rich and famous and make a lot of money. And why are you pursuing this pathway? And so that was the kind of discussion that we had. Eventually, he still sent his application. But later on, I realized that was how he looked at, or that was the approach that he was using to make a change in health service. He was targeting that, in his mind, he thinks as an administrator, he can make a change in health service. So that set me thinking, and I had to look around a bit. And I realized that in Fiji, being a health administrator or medical administrator is not a career. There is no career pathway in the ministry. There are no positions for them, apart from the one that I hold, and a couple of senior medical superintendent positions. Our medical council doesn't register medical administrators as a specialist position. So there is no career. If he goes now, there is no career pathway for him to go through to reach the top and become the next Permanent Secretary for Health and Medical Services. So that got me thinking. I checked with the local university, and there's a training program for health services management provided by the local medical university, and they've had graduates over the last couple of years. But that's it. There's no other pathway for this person or future graduates or clinicians who wish to pursue that pathway. So that little boy has sort of given me my next assignment in reform and change. So that's something that I'm willing to take up. Thank you. Sorry, that's a bit long.
No, it's fabulous, Jim. So thank you. What problems are you working on at the moment as Permanent Secretary?
Oh, that's a big one. There's a couple of important challenges that we are currently facing in Fiji, and some are well known, and some are probably brewing. In terms of disease burden, we know that the NCD is the biggest health threat in Fiji and the region. So there's a whole lot of work that's currently happening in that arena. In terms of the health services, the shortage of healthcare workers is a bit of a killer right now. Since COVID, there's been an absolutely crazy surge in the healthcare workers' exodus from the Pacific and from the ministry, and they come out here, and we know the global healthcare worker mobility that's currently affecting not only countries like us but Australia and New Zealand as well. WHO has estimated that in 2020 there was 15 million shortage of healthcare workers in the country, and that'll improve to 10 million. We're still short by 10 million by 2030. So that's still a huge gap, and so countries like us that train and then produce and export them struggle. And so that's what keeps me awake at night at the moment.
Thank you. And tell us a bit about the work of the Commission and what it's focusing on, and then give us your insights on what you think you'd like to change in the system.
Okay, so the Commission is a national body whose role is to contribute to health outcomes and the sustainability and effectiveness of the system. And we do that working with the states and territories because we're a federated system, leading and coordinating improvements in healthcare, trying to ensure that patients get safe care and they get the right care at the right time. So in doing that, we've, I suppose the Commission's known widely because of the national standards for the accreditation of hospitals, so that we have a standard in in our acute hospitals and day surgeries, and we have more standards more broadly. But what we're trying really to do is ensure that we're getting evidence-based practice that is in working in the interests of people. And in the second standard, we talk about partnering with consumers. I think we should be talking about partnering with people and communities, because I think, and I'm going to go into my one thing I'd really like to change, because I think it's pivotal what the Commission needs to do, and I think that is to increase the focus on person-centred care for health. And I don't say healthcare because I think when we think of healthcare, we have got into a bad habit of thinking of healthcare as a product. It's a drug, it's an intervention, or it's a treatment. But care for health actually pivots the system back to the community and to primary care and to a connected system. And if it's person-centred, it's not technical efficiency. And sitting next to an orthopod reminds me that, and I worked out yesterday, it was 40 years ago, that shows my age. I was a first-year medical student doing a clinic with Gordon Kerridge, actually, who we talked about, and he said to me, I had this lady who came in with a terrible arthritis of her wrist. Terrible arthritis. So I arthrodesed. I just put a bone, and this is 40 years ago, a bone over the joint. And she came back and she said to me, and I said to her, so how's the pain? And she said, Doctor, it's fantastic. And he said, and I said to her, so by the way, what job do you do? She said, oh, I used to be a concert violinist. And it was a great way, I was apocryphal of course, but it was a great way to remind us that the role, medicine has done wonders getting down to technical and reductionism, to getting down to the molecular level. But what is healthcare really is the care, is a health system, not a sick care system, and it's back in the community. And I was reflecting today that if we do this well and we think about it, then what is our contribution to the Pacific region? Well, I would suggest that we'll have a much lower carbon footprint. We all know that the carbon footprint of healthcare is 7%, equivalent to South Australia. We'll actually not be one of the highest users of antimicrobials in the OECD, and we might actually not be driving antimicrobial resistance. And I think we'll have a much more coordinated and connected system, and so we won't be stealing the workforce of other countries, because it may be that we'll be more efficient and more effective and do a better job and need fewer people. The third one is a big question mark, but I think that it's an important thing. So I think we know that we have a lot of waste, we have a lot of duplication. So that would be my goal, is to get clinicians to be thinking about the best way to do things. Allocative efficiency.
That sounds like a very fresh agenda for the Commission. It's wonderful to hear you speak about that. Thank you. Steve, you're also focused on evidence base for health, and you've seen it from a number of perspectives now, certainly from the floor of the busiest ICU in the country to being its director, and now to WHO as well, and recently taking over the reins of the Australian Living Evidence Collaboration. Tell us what you want to see changed.
It's always hard to go last. I think I'd take the last answer as a good one. I think, if you can forgive me, I'd be a little bit controversial. So I would think about it as if some of the speakers this morning said health is a basic human right. I'm sure we all agree with that it should be equitable, and it should certainly, if it's going to be equitable, it needs to be available for the most vulnerable members of our community. So, and we've seen lots of talks today about First Nations people, about gender equity and other things that demonstrate that clearly it's not equitable, it's not working, and it's not working for vulnerable people in particular. And so my argument would be I don't really feel like I work in a health system. So I work for intensive care if I look at my day job, and you can think of intensive care as a little bit of a backstop. Like, I love my job, but ideally you never want to meet me if you're in this room. That would be ideal, or no one in your family meet me. And I wouldn't have a job in 20 years, like it would not be needed. That would be the ideal situation, would time nicely with retirement for me, but that's a bit selfish. But so if you don't want to meet me and you don't want to use that system, and without going into anecdotes, I can tell you most people that come to intensive care, something happened along the way where this could have been prevented. Not always. Some things, just bad things happen and unlucky things, but most things could be prevented. So the system at the moment, and when you trace back over the system has let them down. Especially, and the more vulnerable people are, the more the system seems to let them down. And that also equates to around the world. Having just been fortunate enough to work with WHO, the more vulnerable people are around the world, the less the system works for them. So I guess for me, I feel like the small incremental steps are not really working, and the system is too complicated. It's not really connected as a system. If we were doing a different panel or different situation, and I would say, I'm not doing this for us, don't worry, you're the boss. But, I'd say turn to the person next to you and explain in 3 minutes the Australian healthcare system. And could anybody do that well and effectively and make it sure it all works? And then add a complicated system like I'm in a remote area and I've got some chronic medical conditions and the person's going to have a baby and they might need tertiary care for that, but they obviously want to stay close to their home country. And then explain the Australian healthcare system and how that's going to not let them down in that system. And I would say it's very difficult. And that's not to be critical of anyone or anything that has tried to build this system. But I think, building on Anne's points around the patient and the partners with community and people, I'd agree with that. But the system does need a bit of a rethink. Obviously, New Zealand are going through a major reform at the moment. But I do think that would be my perspective. And when you see it from the intensive care end, and I know it's a biased sample, and many people have good outcomes in the healthcare system, but you definitely see things and you think, geez, the disconnect is strong. Even simple things like, I was trying to think of a grand example and I thought, maybe it's better just to give a simple example. So, the health records in Australia don't speak to each other, as everybody knows. So you don't want to have an accident in Australia, like out of hours, because then I have to call, sometimes I have to fax people to get the information sent across. I can't look it up. So if you're in another state, I definitely, almost certainly can't get the information, and even in Victoria, it's in different systems. So just simple things, and that's not to say that's the thing I would change, but it does demonstrate the level of disjointedness in the system at the moment. So, and then if you had a system like that, then you can build in the other things. If you're working towards a common goal, as I said by Paul before, then you can build things in like an evidence base and things that can all work together as part of a system. But at the moment, it's pretty disjointed and pretty complicated, and with individual parts working very well, but I don't feel like I work as part of a major health system. I feel like I'm a healthcare worker in a great country that tries to provide really good healthcare, and generally it works out okay.
So you've heard some big problems, right? I think big things being tackled by these people here on my left. Things relating to system redesign that address scope of practice issues, better alignment with First Nations people's needs, services closer to home, health records, talking to each other, health equity, a more person-centred approach, non-communicable diseases in the Pacific, the emigration of healthcare workers, and the need for reform rather than incremental change. So I think this really does lead us to, well, what is the role of doctors, nurses, allied health, informal carers, alongside policymakers and alongside the community? Just before we go to that, put your hand up if you're a clinician in the audience. Okay, it's quite a lot. Put your hand up if you're not. Okay, so it's roughly 50-50 in the audience. So we've got a lot to learn from each other. Right. So perhaps I'd like to open it up to the panel now to comment about what's worked well working with clinicians. And let's not confine this to medical practitioners. Let's think, Alison, about nursing professionals and others here as part of the clinical professions. What works well and what doesn't work so well? What is the role of clinicians in health system change?
How comes I always get to go first?
Sat next to me.
I think what works well, if we think about our health system, is when there's clinician engagement at the beginning of the decision making and not at the end. And so when thinking about Steve and this fragmented system that we have, I think that looking at the title, which is Clinician-led Health System Reform, it is encouraging my colleagues who are public servants, and as a public servant, I think, sometimes I get challenged because who am I first? Am I a nurse first or a public servant? And it's sometimes a very tricky path to walk. And I need to sometimes remind my colleagues, particularly in the nursing and midwifery profession, is my role is as a public servant. I can do as much advocating, influencing, persuading, cajoling, but ultimately, if the government I work for and you voted in makes a decision, my job is to follow that. And probably for many of my colleagues, to some extent, particularly during some of the reform we've seen, understanding the roles we play are very important in being able to work to find the common ground we have together, which goes to Anne's point, which is the consumer, the user, the patient, whatever language you want to use, and work out from there. So I haven't answered your question at all, I don't think. But I do think that there's that, for many of my public service colleagues, I encourage them to trust and to believe, but they have to ask the right questions. And it's often about that dialogue, about, again, I go back to that point about finding the common ground. What's the problem we're trying to solve here, and how we do that together. But in order to do that, we need to understand where each other is coming from. And we do look at things through different lenses. And certainly in the role I play in the Commonwealth, trying to see that different lens is quite important, and understanding and asking those open questions that about whatever reform it is we're trying to meet the challenge of.
So, Nick, you've also been central to major public health reform, and you've seen it from the environmental policy perspective in several countries, and you're at the heart of it now. How do you draw on the clinical workforce and your own clinical background, and are they relevant?
So a couple of things. One would be, I think in the context of public health, we think about the patient being the population, so it's a slightly different context already to, I think, the general concept of the clinical relationship with the people being served. So firstly that, I think I'm also a public servant, so I'm conscious of that. That creates a dynamic where there is a requirement to act in a way that is consistent with the principles of our democratic process of delivering health services and making health decisions. I do think that there is a way in which the clinician can be partnering with community, though, and whether that's as a clinician in an intensive care, using the information that you have to enlighten the community about issues and hear what they have to say about it, or whether it's in public health, where frequently we may be looking to try and achieve environmental health outcomes, and actually the greatest allies we have are community, particularly in Aotearoa, the Māori community, who have particular ways of looking at the environment, and so we can find ways of partnering, and I think sharing the different knowledge systems, so we can bring certain, like our epidemiological knowledge, toxicological knowledge, but it can be shared with traditional knowledge, and actually we often find there is a lot of overlap and a lot of shared ambition, and so that partnership can be very fruitful. The role of the clinician, then I think, is also around that conversation between community and the system. And it's a trust-building conversation. So you have to be there, you have to be open, and accept that at times there may be things that don't quite sit comfortably with your training, with your understanding of biomedical science, but they might actually have some validity. So that's, I guess, what I would see as the clinician's role. In terms of the health system per se, we typically talk about the clinical management partnership, but I think where we're heading in the moment in Aotearoa, and particularly in the public health services, is actually seeing that partnership as being not just between management and clinicians, but also with consumers, and also with particularly our workforce, our kaimahi Māori, who have different sets of expertise. So they maybe have experts in cultural practice, which is equally valid in terms of a quality or a clinical leadership approach. So, yeah, some thoughts from me.
Thanks, Jim. So you've given a really good example of what I think is the Pacific Islands showing global leadership in sort of the training and preparation of clinical leaders who've risen to the highest levels of government and health system change as a result. And that's something you should all be very proud of, and we can learn a lot from you in that. You've obviously been thinking quite a bit about what it takes for a junior doctor like you described to us to become someone like yourself in the role that you have. What do you think that journey is like, and what does people need to do within the system to enable that pathway?
Thank you. Firstly, I'm of the opinion that for change or reform to happen in the health system, the clinicians are best placed to initiate and carry out reforms for a number of reasons. Firstly, they are already trained in the service. They are well aware of the field and the issues and challenges that exist in health service, because they've been trained in that circumstances and they practice in that. So they are supposedly the experts in health services in their area of practice. And also, I find that the fact that the experience that they have gained, or the experience that they have, having seen the continuum of care, right from primary to secondary to tertiary care, and understanding the outcomes that come out, and whether it's palliation or rehabilitation. I think that those are important experience that provides the clinicians with the background knowledge and competencies to carry out reforms and changes in the health system. Clinicians, in that regard, they play those experience enrich their advocacy when they advocate for change. It enriches their communication when they are communicating change or managing change or reform as it happens. It allows them to be good collaborators when they are collaborating with the community, with other health partners, with those who are stakeholders in health. And also, it allows them to undertake, to be a scholar, to undertake research and ask the pertinent questions that are related to the changes of the health services in general. So in that way, I'm of the opinion that that clinicians are well placed to initiate but also carry out reforms, provided they are given the tool, provided they are trained and they've acquired skills that can help them to implement change. So that's the role I think that clinicians have that can, make successful changes or reform in the health system.
Okay. Yeah, fantastic. Thank you. We'll come back to the tools in a minute. And safety and quality as a field has clinicians on both sides of the fence, right? It's driven by clinicians often, but often it's felt to be pecuniary to clinicians, holding clinicians to account to standards and performance and so on. How do you see the challenge of juggling the leadership side and the followership side?
Oh gosh, that's a difficult question. So I think we train people in leadership, but in fact followership is terribly, terribly important. And when you talk about safety and quality, you remind me that, as I said to someone recently, if you think about healthcare, safety and quality is not a little condiment that you sprinkle every so often. Everything we do is safety and quality with that broader definition. And I think that what we want, well, I think we've got great leadership, and I think what we want more is clarity of where we want people to go. I understand your frustration of working in an ICU because I think the health system has become or developed, perhaps, that the evolution of Western medicine was one of community, then to the birth of the clinic, then down to a sort of reductionist of super specialisation. But I'm an optimist. I think that we've moved the system, the Commonwealth's moving the system out to the community. And I think there is a great opportunity for leadership and followership in relation to looking after people's health and prevention, primary, secondary, third, tertiary, and doing that by, I know that sometimes it's hard to communicate, but there's just a Commonwealth Fund report came out recently that said that only 50% of GPs said that they routinely got from their specialists, and that's not you because you're not seeing them, you're in the clear, changes to medications or treatment plans. So there are lots of things that we can do within the system that clinicians can do that will actually improve things. I think that certainly in the Commission we've seen fantastic leadership when for example, when we did the Atlases of Healthcare Variation, where we showed marked variation across the country that really couldn't be explained by the social determinants of health, really weren't justifiable. We were able to get fantastic clinicians, and some of them in the room, to really talk to us about the evidence and put into place some clinical care standards and run with it. And I think the best example would be there'd be a number of very good examples, but one example just in terms of women's health would be the clinical care standard in relation to heavy menstrual bleeding. We saw high rates of hysterectomy in parts of the country, marked variation, high rates, and not so high rates of endometrial ablation, and it led us to believe that though we couldn't get the data, that there were very low rates of simple interventions for heavy menstrual bleeding. Now, we were able to get leadership there, and we were able to get people following that evidence. So we had care back in primary care with IUDs, and we've seen over 5 years a decline in hysterectomies, which suggests that there are clinicians who will lead, and there are clinicians who are very happy to follow. And I won't reveal the data, but it looks great. It's improving in terms of hysterectomy rates going down, endometrial rates going up. And it's just some of the examples you see. And I think probably the best example of leadership and fellowship is the hip fracture registry in Australia, where we've had clinicians. We've got something like 119 public hospitals belong to that registry. It's a huge cost to the system. They've been able to drive down the time to surgery, the time to analgesia, I think that's a fantastic example of another example of where we can, if we are clear about what we want of people. And I think what we want of people is to follow evidence, and so our job is to provide evidence, to make it easy for people to do the right thing. And I see that as very much my role.
Steve, you would understand what followership on evidence is about. What makes good followership? How do you support that to happen?
I'm going to go do my discharge summaries later, Anne, to make sure it's all signed. 50%. I think, so probably trust, I would think. It's a good question there, Russell. So I think, I think, we've heard things today about clinicians work in silos. I think that's true. Like we do, we can be terrible that way. We train for a long time in certain things, so we become blinkered to what other people need, and whether that's craft groups or within specialties. We obviously all have a sort of bias towards where we are, so it's hard to sort of put yourself in the position of other people. We do our best, but it's always tricky. So I think so why do you do that? You don't wake up in the morning and think, I'm going to work in a silo. Like no matter what the person says, I'm not going to listen. That's not how you wake up in the morning. So why do I do that? And so I guess there's a number of reasons, and strengths and weaknesses could be part of it. But I think one of them would be trust. So if you think about legislative or government or jurisdictional leadership and followership from clinicians, it usually relates to trust, as it would with any other organisation or group. So, and we saw that probably play out quite well in COVID. So some things in COVID were done very well around Australia, and it's probably easy for me to talk about the thing was closely involved in. So the intensive care outcomes in Australia and New Zealand were very, very good, and acute care in general was good. Was at a high level. Obviously, some people had bad outcomes, and that was what we were working against. But the reason I say that is because there was periods in that there was very high degrees of trust between clinicians and government, for want of a better word, or leadership. So we were able to work very closely about simple things. What do you need as clinicians? What do you see as the problems that are coming? And we would say initially it was concerns about equipment and fear and infection prevention. Then it became obviously very apparent that it was going to be workforce, and that was going to be the challenge we weren't going to be able to meet. And those discussions were able to be had with a lot of trust and rapidity. And so I think that's an example of how we were able to get it right. And if you can trust between the two groups, then you can move forward and you can move things. I think clinicians, we forget we're taxpayers as well. We don't want to blow the budget on healthcare, but we do think it's an important thing to provide for the community. So I think that, as was said before, we talk about sort of clinician partnered or anything, but really there's always going to be followership and leadership, like you're saying, Russell. It's really, can you trust the information? Can you trust? Do you trust the people from your group, your sphere, your craft group that have been involved? Have they had the chance to put forward their argument about what's happening? Are they good enough and effective enough to have listened to what the other people were saying? And have they come up with the best possible solution moving forward? Which almost certainly won't be what you thought it was going to be. It'll be some compromise. But I think that is where we've let ourselves down a little bit. It's very much a sort of a to and fro, as opposed to, well, let's try and work together and trust each other to come up with the best solution. One of the reasons I like my job in intensive care, and I've always liked it, is because you do get to deal with nearly all specialties, really. Maybe except dermatology. We don't have a lot to do with dermatology. But most specialties we get to deal with. And so that's a great part of the job. You get to hear a lot of the stresses, clinical challenges that other people have. And so I think I've always enjoyed that. But you can see when you develop that trusting relationship, even between clinicians, generally, the work is easier, it's better, it moves forward. There's no reason why that wouldn't be replicatable across a bigger system, if that makes sense. Thanks.
And on the topic of trust, a lot is made of the public trusting their healthcare professionals and being distrusting of government, I think, is the implication in those statements quite often. And I presume that is a statement that's often being used by health professional associations for whatever of their own purposes. Do you really think that is the case? And Nick, perhaps we'll go to you on this, and then Alison, we'll go to you. And if so, is there a way of harnessing that trust in health system reform?
Wow, it's an interesting time to be asking about trust in public health, isn't it? Obviously, there has been some loss of trust post-COVID, and we've heard a bit about it this morning. There's a lot of factors sitting in behind that. So I don't know that I can unpick that here today, but I do think early on in COVID there was an enormous amount of trust in public health, and people finally actually learnt what it was actually all about, which was quite unique. Can you remind me what the question was? 'Cause I'm struggling a bit here.
Does the community's trust in the health professions become an asset for government, and if so, how can they be utilised?
Well, it could do. I think if we do it well, yes, it will be a huge asset, because at the community end of the day is going to be how we get change. Politicians follow the views of their communities. They don't generally lead them. They actually listen to what their communities say. And so if we build that relationship with our communities and it's perceived that the things that we're sharing with them are things that resonate with them, then I think that will be a huge asset.
Alison, the health professional groups, whether it be colleges, the AMA, Nursing Federation, the academies, they've all got a dual interest in sort of advocacy on behalf of their members and their purpose, and public interest advocacy, as I call it. And they aren't the same thing. It's often not transparent or declared as which they're prioritising in any particular advocacy instance. How does government deal with that, where professions come to you arguing for various things, and that some of that is self-serving and some of that must be public interest? How do you sift through it? How do you make use of it?
I think that it goes to a little bit to what I said earlier. So if I think of we brings unique things to the table. So you have to be upfront about that and transparent. And I think that authenticity in coming together, I think particularly, again, in the early days of COVID and wanting to build that trust. And there was a legacy structure that I inherited from my predecessor, which was essentially 20 of the key nursing and midwifery peak bodies came together once a quarter to talk about stuff. We used that pathway and that avenue as a way to communicate, but it was very clear at the outset that it was a two-way communication, that I needed them to help me understand the impact on the ground, and I needed to help them understand, to some extent, the complexity and the challenges of public health decision-making of government. But there was a lot of trust, and whilst there were on occasions quite forthright conversations about decision-making and some of the challenges, the thing that comes to mind is mandated vaccines, which remains, of course, a contested area of decision-making. But I think that inherent trust was critically important in understanding each of others' views. But it was about finding that common ground. And I think too, if I reflect, Steve, with some of the discussions we had in the early days with ANZICS and ACCCN, we had the two key bodies at the table. We had the ANZICS, the medical body, and we had the nursing body together, working together, to look to solutions to the challenges we knew we were going to face going forward in COVID. So I think there is that measure of authenticity from both sides, the trust that comes from authenticity, and the need sometimes to agree to disagree, because sometimes there are things that you can be respectful of each other's views, but you will continue to disagree, and that's okay. So I think, in my mind, that's how we have learned as a professions, particularly I think in nursing and midwifery, to be able to bring forward some really positive policy ideas and reform, because we've been able to work through those things together to find the solutions that we're looking for.
Joyce, what about the professions in Fiji? Are they powerful? Do they control the agenda? How can you work with them from a government perspective?
Thank you. The experience that we had around COVID was similar. We also had members of the community who were questioning, the actions that we've taken, the decision that we've made, and we also struggled with challenges to some of the things that we did, and there was some element of distrust towards health workers and the health policies that we have put in place. But we found that from our experience that when there was transparency in the way that we handled the decisions that we make, if we were making a mistake, or if we were making a change that was based that the evidence for were not complete, when we were open and upfront with that sort of restored the trust or maintained the trust that the people have. The other important bit is to ensure that the science that we are referring to the science around the actions that or the decisions that we make all the time. So it's important for young leaders to be well trained. Leaders who want to make a change or want to reform a system should be well trained, do the education that's necessary, build capacity, because that provides the skills and the tools for us to start a change, to communicate a change, to manage a change right through the chain from the start to the finish. And that only comes when you are confident with what you already know and what you understand.
So what does the health professional of tomorrow need to know that they don't get trained in today?
They really need to, if you haven't done management, you need to do some sort of management course and understand that, in addition to your clinical knowledge, have an understanding of management tools, or how you communication tools, and how you interact with non-health people who are usually normal people. What they prefer, what they prioritize in their lives. And lastly, we also noted that when you are working with passion and you are showing the passion for the conviction and the commitment for the work that you do, people see that, they recognize that, and they migrate towards it, they lean towards it, because they know that you've got something that you are convinced that will work, or that will improve the service or the overall environment that you work in. Thank you.
Thanks. And what do you think should be in the curriculum for healthcare professionals?
Yeah, I think it should be very different to what I learnt.
In what way?
Well, I think that I learnt a lot about the pathophysiology of medicine. I was just reflecting with someone recently, being a physician, you'd do a short case where you'd have to examine someone's lungs or neurosystem, but you never had to demonstrate your skill to explain a procedure to somebody, or to do open disclosure, or to break bad news. So I think that in undergraduate training, it should be learning to talk to people and what matters to them. So I do that. I think the other thing is that we have to recognise, I think, that health comes from much more than what we define as modern medicine. There are fantastic things in modern medicine. We do need intensive cares. There's a whole lot of molecular things. Absolutely, but we do know, and we don't actually do enough of it, is recognise that health. There's the social determinants of the health. There's the economic determinants of health, and and people want to be healthy. They don't want just a healthy wrist or a healthy whatever. They want to be healthy. So I think I'd be making sure that undergraduates understood what is the purpose of the healthcare system, how it can best achieve it, what are the current barriers and how they are either contributing those barriers or diminishing those barriers. And that lack of communication, I think, is a huge thing. Communication with patients, communication with our colleagues, communication with patients is a major barrier, I think, to how we're travelling. But I think the other thing is that I would be training people to recognise, as I say, that broader health. It's the environment. We're treating the person with respiratory failure in hospital, then sending them out to the pollution and being surprised when they come back. So, I think I would be having a much broader approach to education and multidisciplinary.
Nick, that must be music to your ears as an environmental public health guy.
Yeah, I was just thinking about, the tools that we need, and I would include financial literacy, in that learning about management. You can't lead and engage in system reform without getting your hands dirty around the financially constrained environment. And clinicians, we've traditionally tried to avoid those difficult areas, and said, well, we just want the best care for everyone. But we can't actually be in leadership roles without having a mastery of that area of decision making. And I think another one would be around the ability to communicate with decision makers, whether they be political leaders or other senior officials. The question around training, I think from a public health point of view, there are so many areas of interface between our discipline and so many others, whether it's roading engineers or, people who are planning agricultural, the delivery of food services for a country. We need to be able to speak the language of farming so that we can actually influence the decisions around which foods are produced, because that's what actually is ultimately going to be consumed by our people. So I think there is there's sort of an interface role, which is learning these other vocabularies and languages.
I'll just add one other thing from my list, and that is data literacy. I think that without being able to measure the impact you have, you don't know where you are. So I think whether you lead or follow, you've got to be able to measure the impact. Yeah. It's not a warm and fuzzy feeling.
And Steve, you provide the most expensive care on the panel, right? So tell us about whether clinicians can really wear dual hats here. Can they provide the best care for their patient and advocate for that at the same time as being responsible stewards of healthcare expenditure?
Yeah, I think so. It's no different to other professions in some ways. It's a good point, and it's good feedback, I guess, around the clinical system. I guess we hear a lot about how much healthcare costs. It costs a lot to provide intensive care, and my colleagues would help me say this. If it was up to us, we would give some of it away to mental health tomorrow and other preventative things. Like we are trying to service a need. We don't create the need, if that makes sense. So in many ways, we feel quite guilty about the amount we spend, to be honest. But if you think about it from another point, we don't hear a lot about how much healthcare saves. So if, God forbid, someone crashes their car on the way home today and they're 30 years old with 3 children, that saves the community a lot of money. So then it's sort of naive and silly to say, oh, well, the intensive care stay cost $100,000. Because I'm not a health economics, but I know enough about it to say that person's life saved is a lot more than $100,000. Obviously, the person and social cost is far more important, but the cost is much bigger. So we do talk a lot about the cost of healthcare, and I was interested this morning about that there was this huge talk about the cost, it's too expensive, but we don't actually say how much is good healthcare providing. Obviously, the most cost-effective, and you don't need to be health economics to work that, would be prevented in the first place. That's going to be the most effective thing. So in some ways, I think that's where the argument gets a little bit tense, is we talk about it costs too much, instead of saying, well, how much are we spending and are we getting value for this. Obviously, again, from a human point of view, first of all, but also from a cost point of view. So, are we spending... We know that things like smoking cessation and seatbelts, public health interventions with huge flow-on benefits. So in some ways, some of the simple things have been attacked, but we know there's other things to do. So I guess that's one thing that clinicians could help with. It's always better, I guess, in my approach would be always better inside the tent. And I think even the way you framed the questions today, Ross, no offence, is like two tents. Inside the tent, outside the tent, clinicians versus policymakers. It would be much smarter if there was like one tent and everyone was inside the tent. That would seem more logical. And then, as you say, people will have different skills and different training. So I agree, but I disagree. You don't want every surgeon, no offence, am I allowed to make fun of surgeons? Just a little bit. You don't want every surgeon, you don't want the future great neurosurgeon, and she's amazing, and she's going to, and then saying, now I'd like you to go off to management school, please, and do a 5-year MBA. If she's the best neurosurgeon in Australia, maybe she should be doing neurosurgery and learning skills, obviously. But it is about, as a system, working together as clinicians, and I think that's where we could be stronger. But I do think it's most important that everyone's inside the same tent. The financial one is clearly a very good point about that shared language and shared understanding of cost versus benefit. The mental health example I gave was a purposeful one, because we see a lot of that in intensive care. So people with mental health issues often end up, many people with mental health issues will at some point need hospital-based services. And it's tough to see, because those problems are wicked problems. I'm not an expert, but you think, more investment in that area, surely we could do more for these people than wait until they need acute care services before we then it seems like, from our perspective, that's when a lot of intervention happens. Now, I know there's a lot more happening, but it's sort of a frustrating thing. So that's probably the one thing I would think. And again, to Anne's points, I think understanding evidence, and just from, if you forgive me for a sec, for the tools, I think that's the really important thing. So probably the best anecdote I have is when I was in Darwin as a junior doctor, I made a mistake and I sort of got chewed out by the boss at the time, which was fair enough in those days, not probably okay now, definitely not okay. Got told off, and another boss who's very nice, he's still up there, he came over to me and he said, look, people forget now how hard it is to be clinical now. He said, in the 1960s, and no offence to anyone who's working at that time, he said, if you had a heart attack in the 1960s, you got given an aspirin, and the doctor said, good luck. And that was all you really had to know. That was all that was available, and that, they put a monitor on you. Whereas now there is a huge amount of data and evidence to work through. Obviously, I've worked for guideline groups, and Anne is involved in this as well, so we would have a strong penchant for that sort of thing. But I think it's now about clinicians knowing, trusting guidelines and clinical practice, so we get consistent practice, and then expertise to go beyond that when it's needed for other things. So that's another thing I think that is different to the apprenticeship model, where you're trying to learn everything as a nurse or a doctor or allied health professional, and then later in your career you're sort of putting that all into place. That is impossible now. So you need to be able to follow the guidance, work out yourself what you're going to do. Probably keeping up to date is probably not really realistic anymore. You need tools to do that, and you need organisations that are doing that for you. So, I guess in summary, one big tent would be good, and clinicians learning other skills is important, but probably not one size fits all. I wouldn't say that everyone should go and do an MBA tomorrow. That probably would be extreme, just to be controversial maybe.
I think there's a benefit in building the clock, not telling the time, i.e. building out the capacity in the system, very intelligent people in the system. And I suppose that's... it goes to that point about how many leaders do you need and how many followers. Well, I think that, there is so much that can be done out in clinical practice by clinicians who've just got the right support and framework.
So thank you. At risk of, the big tent being a circus tent, Alison, you started talking about silos, roles, and role substitution in a way. There's a conversation here about interprofessional engagement, interprofessional education. Can you tell us what your thoughts are about the future of interprofessional education, that is nurses, allied health workers, doctors and others, training together, learning how to communicate together, learning how to work together as teams? It seems to be of particular interest.
I do think that there is definitely a place at the undergraduate level for more interdisciplinary learning, multidisciplinary, whatever jargon word we want to say. There are core elements, and the thing that comes to mind often for me is cultural safety. we should all learn cultural safety together at a fundamental level of our learning, whether we train or learn in a university, in a TAFE, in whatever element. There are some core things that we should all learn together, because it means we have shared learning and shared understanding. There are probably many more that the principles of infection prevention and control, we all, these are fundamental elements about the ability to talk to patients and understand patients. These are all skills. So I think if we had an opportunity for more interdisciplinary learning, and I hate myself for doing this, but I'm going to do it anyway. It's just because, of course, I'm so mature in my nurse training. I trained in the hospital system. Whilst I don't advocate for a moment to go back to that, there were more opportunities for interdisciplinary learning and interdisciplinary understanding. So if we can do more of that, and I heard recently of an idea about how we can get, and this is not my idea, this is someone brought this idea to me, get more of our undergraduate learning in rural and remote, is by developing learning towns where we build the ability for our undergraduates and postgraduates to learn together, but to learn within a town or a system that will support them to do that. Because so hey, wouldn't it be great if Broken Hill became a town that prided itself in supporting the growing of future workforce, health workforce, that it was a town where the local pub might have the accommodation you needed, and the local Rotary made sure that they felt they had a place to learn in and a place that welcomed them, and to learn what country life might be like in order to track them. So we have to think outside the square that all learning is in large tertiary centres in the middle of the cities, and that's just a simple example. But I do think that we who are clinicians in Australia need to lobby our regulatory system to make that the intent rather than the byline. So we control our regulatory system. It is our system, and we need to be persuading those that regulate us that they need to regulate in a way that will make our learning better in the future.
Fantastic. Interested if you've got any questions or comments of the panel. Yeah, please come up to the microphone. There's, I see a number of hands, so feel free to get up and stand up at the microphone, and we'll go through in order and sequence.
Hi, thanks everybody. My name's Julian Grant, and I'm Associate Dean Research for Faculty of Science and Health at Charles Sturt University. Thank you all so much for the conversation so far, but humming around in the back of my head is there a few little things that I feel have not really been attended to, perhaps as much as they might. One of the things when I look at clinician-led health system reform, I reflect on who the clinicians are. And I look up on the stage here and I go, what system have you been educated in? And what I kind of come to is that a lot of health workers, professionals, were educated in the mainstream health service system, socialised into Western binary scientific epistemes. Now, what that means for us is that when we're in the health system, we're often not very open to other ontological, epistemological positioning, which I think is one of the major things we need to be considering if clinicians are going to reform and health systems are going to be able to reform. And a couple of things that were said throughout this afternoon really sparked that for me. And one of them is the focus of evidence-based practice and evidence-based change. Now, my cultural peers, my cultural mentors and my cultural guides are very challenged and share with me their challenge about the language of evidence-based everything. There is a place for evidence-based practice and scientific reform, but there's also a place for evidence-informed change, where evidence-informed change accommodates First Nations ways of knowing, being and doing, refugee and migrant epistemes and ontological positions. And I think until, as a system, we start considering those at the forefront, we're really not going to make any difference at all. Because the patients, or should I say, the individuals, the communities, the people that live and work that we serve, are often those that experience the greatest inequities and don't actually come from the same epistemes. The other one is patient-centred care. My First Nations colleagues say, we're not individuals, we come from community, from culture, and we need family and community-centred care. And then just the last tiny little one, I live and work in regional Australia. I've lived and worked as a clinician, nurse before I became a professor of nursing. And in those remote communities, I can say the health system doesn't work. And it's really frustrating when we sit here and hear people say, oh, well, we get the metropolitan area sorted and then sorry about this, I think it's Steve, then we add on and think about the remote areas. Until we start actually positioning the remote and the regional centrally and think about us as part of the whole system, not a tack on, we're not going to get any reform. So I'd really like to hear your comments about my reflections. Thank you.
Steve, maybe you can start.
No, I would agree. I think that just... and I wouldn't profess to have the same experience, but most of my training was done in North Queensland and Darwin and working for flying doctors in remote North Queensland. And so I would agree. I think it's an immature health system. So probably the reason we speak about evidence-based medicine and other things is that you would think that would be one, and I hope this makes sense, you would think that would be one component of providing... I find One Health a slightly confusing terminology, but you can see what I'm trying to say. From providing healthcare for people in their community, their place, their home, evidence-based medicine is one component, as you said, of that. What goes into that also is their culture and all the other parts that make them part of the community, the place, the region, the world. And we don't do that very well. So I think, to me, a bit like I sort of said at the start, like it's not really a system, it doesn't really work. We're still talking about evidence-based medicine. Maybe that should be an assumption for where there is really good evidence for things. I'm sure that is probably what you mean. There are some things that exist, but there's many things that needs to be discussed in a wider framework. Having just come back from the WHO, working for them in the Health Emergencies Program, you could sort of say that is the issue globally, is that there is transplantation of Western medicine into multiple places around the world with a really minimal attempt to listen to what is needed in these places, and then the transplantation is an epic failure. So, as you can imagine. So, look, I can only agree and say that it maybe as the only sort of saving grace would be that I think it shows an immaturity of the healthcare system, and it's really how do we build that to make a more mature system that does look after people where they are, all the things that you said more eloquently than I can.
So, Nick, is New Zealand a more mature system in that sense?
I wouldn't want to claim that. Look, I do think, and you will have heard me talk about Mātauranga Māori knowledge as being something that we are trying to embrace within the health system. And I reflect on my own journey, because it is a journey. I come from a privileged Pākehā background, grew up in a privilege and was educated in the Western education system. So, yes, what you're saying is entirely true. But I think as a practitioner, we can work to overcome that and actually to become more adept and more agile in the way we think. So I guess that's at a personal level. I'm wondering at the system level whether there are things we can put in place that can make that journey easier for clinicians. So working in a national role, one of the difficulties I've had in adjusting from where I was previously working in a district, I had close personal relationships with the First Nations leaders in that area and strong links that informed my practice. When you go to a national role, it's much more difficult because there are lots of different groups. So I do think there may be something that a health system can do that ensures people do have access to that knowledge, which will be regional and locally specific. And, you know, there are attempts at the moment within the health system reforms in New Zealand to make that explicit around the role of whānau voice or family voice, putting in place mechanisms that help to deliver that.
Great. And I presume you weren't necessarily excluding anyone when you're talking about patient-centred care, but
Yes,
what do you
I won't
respond to
sort of
Julian's
debate
comments?
terminology, but the concept really is to make sure that our health system is actually working for the people who it should be working for. And I take your point that, you know, for some people, for Aboriginal and Torres Strait Islanders, it is community, is a descriptor, but it should be working for them. My other point is I'd say yes, rural and remote is very difficult, a tough problem, but we certainly should be working on that. And as I say, what we saw on the atlases, there was very little healthcare provision in rural and remote Australia. And I think to your, I've forgotten your third point, which evidence-based medicine. Yes, I mean, I think that what I'm trying to say is that we should not be doing things for which there is no good foundation, except perhaps that I'm technically a gastroenterologist and I can do it. So, you know, I'm not suggesting we should take Western medicine, but we should be doing things because they add value to the recipient.
Thank you, Rosalind. My name's Stan Kapp and I'm a board director at Bendigo Health, having had about 30 years' experience as a CEO in various small and large organisations, both in Australia and overseas. I would just like to say that I'm not a clinician, and I just wanted to balance up the discussion just a tad to say that clinician-led health system reform may not be the only formula, and I think we've heard that from members of the panel anyway, and I would like to say that there are many people who have got a great background and knowledge who would like to be inside the tent with Steve and his colleagues when we're looking at systemic reform. That's just a comment, if I may. My question, though, is about priority setting in healthcare, and I'm very interested in the community engagement processes that we can have that inform what we might do. And I was taken by the example of the 30-year-old admission into intensive care, and I do wonder. And I did do some work on this a long time ago, asking community what they would think about a 90-year-old that would come out for an accident where the cost was not 100,000 but 150,000, which are much lesser likelihood of a good outcome, and whether or not we should be making decisions about that. And what that does is beg the question about how we do involve the community, not just in health system reform, which I think came out of some of the discussion anyway, and really ought to be just a no-brainer in many respects, but also about how we engage the community in understanding what the priorities are for our healthcare system per se, not just necessarily on a ad hoc basis, on the basis of a clinician fancy.
Dane, I think that's a terrific point, and thank you. And of course, I'm sure Steve's big top has plenty of room for non-clinicians. But I do want to just finish by asking each of you about your own personal journey and what one or two key things were there. For the 50% of the audience that are clinicians, some of them will aspire to positions like you have now. What was it in your own journey that were key moments or key enablers to reaching the heights that you have? Perhaps start with you, Alison, and work around.
I was incredibly fortunate to have had some great mentors that have helped me throughout my career. I think for me it goes to some extent to what Nick said, which is the step that I took from being, which was essentially an intensive care nurse or a nurse teacher, into the world of management and leadership and new skills I had to learn. And so the thing that I try to share with my with emerging nursing and midwifery leaders and all health clinician leaders is you need to know and understand the system you will operate in. If you want to advance your career as a leader and a clinician, then you need to take the time to learn. And I know we heard absolutely not everyone needs to do an MBA, but if you want to aspire into leadership and management, then you need to know and understand the system. And that's because then you will have the knowledge and skills to be able to influence and negotiate with those that you need to work with. So that was the thing for me, was the transition. I was privileged and probably I learnt something along the way, and it was not to shy away from who I was. I'm proudly call myself a nurse today. I'm still registered, though clinically I'd probably need a little bit of help today. But I am proud of the profession I come from, and I want to show that leadership to other nurses and, of course, our colleagues in midwifery as well, that we should be proud of the profession we come from, be proud to be a nurse, and to make sure that that's clear. And that wasn't always so in my career. There were times when I probably, in my inexperience, wasn't as proud or as willing to express that as I am today.
Nick, was there a particular moment that shifted your trajectory?
Probably not one particular moment, but there have been several that I do recall. You know, I think early on in my career, I saw myself aspiring to technical excellence, providing expert advice around epidemiology, data, informatics, geospatial information systems, a lot of technical areas. And as I matured, I think I became aware that there were opportunities to be working in a different way, and not to put aside all of that expertise, but to actually think about people leadership and about the softer skills, communication, articulating and reflecting on values, and I think most importantly, probably thinking about the future generations, the future practitioners, and being part of the pathway for how that next generation is trained and becomes who they need to be.
Thank you. Jemisu.
I was a practicing surgeon, and at the peak of my clinical career, and then the reform came in, and they wanted someone to be appointed as a clinical director, and I was the last person that stepped back, and so I got caught, and that was my introduction to management. I walked into a room one day, and there were a number of very junior clerical officers who were sitting around a room, and they had a big Excel sheet. At that time there was no Excel sheet, there was just a big white paper, and there were tables on the paper, and names of doctors would be put on the paper. And then I asked them what they were doing, and they told me that they were writing down the training plan for doctors in the Ministry of Health. And so I asked, where are the doctors who are supposed to be here? And then they said that, no, we called them. They said they were very busy, just go ahead. And so that really struck me, because here was the training plan for the next 12 months, and none of the people who were going to be affected were in there to put in their input and decide what will happen. And that's the incident that pushed me towards management. So I came in without any training, and I was put into that position. And so, hence my earlier message when I was saying that not so much do a management course, but have those skills in place to be able to communicate and, as discussed, know how to handle data and finance. Yeah. And
great. And what about you?
Yeah, it's a difficult question. There's no particular moment. I suppose the first moment was when I actually trained to be a teacher, and then was teaching this very disadvantaged group about the agrarian revolution, and decided that wasn't really useful for these kids who had single parents and sometimes lived in cars, and thought, oh no, I'm going to do medicine. I'm going to do, because it's medicine actually offers an enormous opportunity to do all sorts of things. And I think I've just always just done what I thought was a fantastic thing to do, and opportunity came. And I still think that if you look at the broad spectrum of medicine, people do fantastic work, and I think there's great opportunity for in Australia. We're a rich country. We have great potential. We've got so much going for us that we can actually do such good, and I think this generation can actually educate the next generation, and we can do an enormous amount for global warming, which I think we should do, and there's just so many other challenges, and maybe it is that I just like to challenge, and opportunity knocked, and that's where I've ended up now. Yeah.
And Steve, you always like the combination of machines that go ping and global emergencies, or is
Yeah, no, I do. I mean, it's a difficult question. So, I think from a health equity point of view, I've always been interested in that, even though it does seem strange coming from an intensivist, and I've had lots of opportunities and been very privileged then to have those opportunities. I think from intensive care, I was lucky. I think early on I realised how privileged it was to get to sit to someone that's having the worst day of their life, either the family or the patient, and that was a big moment for me. And I think in terms of health system improvement, the one anecdote was when I was working for flying doctors. It's a bit embarrassing. I was in the back. I think I was the plane. We were flying somewhere, and I was watching a movie or reading a book. And the pilot would often say, "Can you read out questions?" Because they would get tested every 6 months on their system, and the air traffic person would also get tested, and they would get. And then I would read the questions, and he would answer, and we'd go through scenarios. And then one day he said, Ralph was his name, a good friend of mine. He said, "Steve, why don't I ever get to ask you questions?" And I said, "We don't. Oh, we don't." Anyway, and then I realised how much effort went into the air traffic safety, that I could feel so safe in that plane. And I was like, medicine doesn't, and healthcare generally, it's much more loose in many ways in terms of safety. So from a safety and quality point of view, that was the thing. I think I always remember that moment as being like, if I can be involved in any way that improves the safety, as you were saying, not so much evidence-based, but just the safety. Is it safe to go into the healthcare system at primary care, regional, rural, doesn't matter, then that would be a good thing to do.
I think you'll agree they've been an inspiring panel, and it's been a great conversation. Thank you very much for Alison McMillan, Nick Jones, Tedru Sedru, Anne Duggan and Steve McLaughlin. Thanks for being a great audience, and off to the welcome reception.